Great, okay. So one more case I wanted to review today is a cone after a Fontan procedure. So this patient was a 7-year-old female with Ebstein's anomaly of the tricuspid valve and diagnosed with pulmonary atresia at birth. She was followed at an outside institution and had a Starnes procedure with a modified BTT shunt at 7 weeks of age, then underwent a right bidirectional Glenn procedure with shunt takedown at 6 months of age, and then subsequently had her Fontan procedure around 2 years of age. She had some other medical comorbidities that were listed here, but most importantly, she had this concern for Alagille syndrome with a variant of unknown significance in the JAG1 gene. She had liver dysfunction, and that was significant and thought to be highly contributed to by her Fontan circulation. So given her liver disease and at a young age with her Fontan circulation, her team there referred her to the De Silva Center for consideration of Fontan takedown with a cone procedure. So just like all of our other patients who have had prior surgeries and interventions, we asked for the newborn echocardiogram, and we were able to take a look at that and look with the De Silvas and have them determine, is she a candidate for a cone procedure? And so based on her neonatal imaging, there was felt to be adequate tricuspid valve tissue to proceed with that cone procedure. This was her preoperative MRI. Again, looks similar to our other patients with a Starnes patch in place. The RV is very small, decompressed, dysfunctional. Her left ventricle had good function. And so she, the De Silvas felt that they could do the cone procedure and Fontan takedown in her, so they did proceed with that. And at the time of the procedure, based on the inspection of the pulmonary valve, felt that it was adequate, and the leaflets looked normal, and so it was likely more functional pulmonary atresia in that neonatal period. So she had Fontan takedown, cone procedure, pulmonary valve repair with MPA enlargement, and her Glenn was left intact. So this was her postoperative TEE. You can see the tricuspid valve repair there, and it was functioning well with really just trivial insufficiency. And this is looking up into her right ventricular outflow tract, which is unobstructed, no stenosis, and no insufficiency. She did come back to us for follow-up, which was great, about 6 months after her procedure. So we were able to get an MRI here at our institution in Pittsburgh. And you can see that right ventricle, how much it's grown since her procedure. The tricuspid valve is functioning well with really just trivial insufficiency. This is a nice view of the reconstructed tricuspid valve on FOSS. And again, that right ventricle, the function's improved significantly, and the size has also made big improvements. This is beautiful 4D flow imaging of that right ventricular outflow tract, which is unobstructed, no real insufficiency, and that tricuspid valve is functioning well. You can see here in several different views with just a trivial gradient and no insufficiency. Here's her follow-up MRI with 3D reconstruction. You can see that Glenn is still intact and unobstructed, good-sized branch pulmonary arteries. This is her right ventricle, which has grown significantly, and she has an unobstructed right ventricular outflow tract. And this is looking at her MRI quantitatively. Her RV end diastolic volume was very small to start and over doubled after her procedure. Ejection fraction of the right ventricle improved significantly and was just mildly depressed at 6 months follow-up. The LV volume stayed the same, but even the LV ejection fraction improved with a higher percentage of ejection fraction and higher stroke volume. The ratio of the RV to the LV, got closer to 1, knowing that her Glenn was still intact. So I wanted to invite up Dr. De Silva to talk about surgical techniques for this specific procedure of cone after Fontan.